Senator Murphy.
Thank you, Mr. Chairman. Thank you to all of you for your testimony and to the VA and all of the staff you represent. A lot of veterans in Connecticut who are very pleased with their care, very proud of the association, so thank you. Dr. Clancy, I wanted to drill down a little bit more into this issue of care provided to veterans with bad paper discharges, those who have less than honorable discharges. The numbers are pretty startling. If you have an other than honorable discharge, you are twice as likely to commit suicide. And if you're outside of the VA system, you're somewhere around 30% more likely to commit suicide. And I think the VA has recognized that. I had a back and forth about a year ago with Dr. Shulkin about the statutory authorization that I believe clearly allows the VA to provide care to those that have bad paper discharges. Again, these are individuals who have not been given a dishonorable discharge, but because of some conduct that they engaged in that was likely connected to their injury that was caused through their service, they have been given a less than honorable discharge. You've made a decision now, and you noted this in your testimony, to provide a small amount of care, 90 days of care, to individuals who are in emergency circumstances. So let me first just get the predicate question out of the way. There was for a while a uncertainty about whether VA had the statutory authorization to provide this care to individuals who have bad paper discharges. Is that, with your decision to provide care in this limited manner, are we now clear that the VA has the statutory authorization to provide care for this population?
Yes, and I think the sense of urgency that came out at the summit that Dr. Shulkin had just over a year ago, Dr. Ramchan was quite insistent that if we were serious, we needed to focus on veterans with bad paper because of the increased risk. And as you point out, some subset of that group, which we believe to be just over 500,000 altogether, may actually be able to confirm a service connection for that diagnosis. That will take time to evaluate, but in the meantime, they will have at least that initial 90-day period. For those for whom we can't document that connection and therefore get them a path to enrolling in VA care permanently, then we will have time to actually enroll them and get them connected with other sources of mental health care.
As you know, a very well-publicized recent report identified within the Army as that subset being 24,000 veterans who had a less than honorable discharge, who had a service-connected disability, but were denied services in some way, shape, or form because of that less than honorable discharge. So then if it is clear that you have the statutory authorization, why limit care to 90 days? That's not a number that's based in medicine. Many of these veterans have no other outlet for care besides the VA. Why the 90-day limitation if there's not a dispute any longer over the statutory authorization?
So we can provide care on a humanitarian basis to anyone who shows up at one of our facilities on an emergency basis. That is a given, veteran or otherwise. 90 days was what we thought was a reasonable time frame to establish whether they could be permanently enrolled in VHA. And our lawyers agreed with that call after doing a lot of deep analysis of existing statutes.
So there is an opportunity then at the end of that 90-day period to stay in VA care?
Yes,
okay.
If we can establish service connection or other eligibility, yes.
And then this term, emergent mental illness or someone who's in an emergency status, that again is what's the guidance given to people who are doing intake as to what qualifies as being in emergency status?
So in general, it is more or less a prudent layperson. If the veteran thinks it is urgent, period. I mean, I'm referring to prudent layperson as a broader definition for use of any emergency room in America by any person, right? If you call it an emergency, if you, the patient, consider it an emergency, it is, period. And as you know, we have made access to care same day available for all the people enrolled in our system at our major medical centers as of the end of 2016 everywhere, same day for primary care and mental health. And in addition to that, we've reached a lot of the outpatient clinics already, and over the next couple of months, we're going to close that gap so that actually you can go anywhere, and we will be following that very rigorously.
I think this is really important progress that you've made here. I would argue that there's no reason to limit the care to those who are in emergency situations, nor to limit it to 90 days. And you're talking about the most vulnerable population. You're often talking about young men who just went AWOL for a short period of time because of a very serious service-connected disability, because of a TBI or PTSD, and because of that, they got a bad paper discharge, and then that disqualifies them for services. And again, you're talking about a number that we know is in the tens of thousands at the very least. So I would hope that you continue your progress on opening up the pathway and not having these, what I would argue are arbitrary limitations. And I don't think you need the statutory authorization, but to the extent you do, I
We
don't
will
see
be back.
any
I
reason why
promise
we
you
wouldn't
that.
why we wouldn't try to work together to give it to you.
And I think part of working with the Department of Defense, you know, in a tighter link and integration isn't just the transition. That's important, but it's also upstream in terms of the kind of evaluation that you just referenced with respect to the Army.